Good morning, everyone. Thank you so much for joining us for today's webinar, Preventing ACEs in Ohio, Promoting Positive Social Norms and Intervening to Lessen Harms. My name is Haley Aka. I'm the Vice President of Operations and Strategy at HPIO, and we are so glad to have you with us today. On the next slide, you'll see HPIO's mission and vision. We are an independent and nonpartisan organization. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in Ohio. I want to take a minute to thank our core funders who advance our mission with their steadfast investments in our work. I'd also like to thank our 2024 Educational Event Series sponsors for their generous support of these events. We'll have a little time during our short webinar today to answer some questions. So as our speakers are presenting, please feel free to type any questions that you may have into the chat or into our question box, and we will address those as time permits. We also have some poll questions for you at the end of today's event, so please stick around for those. Today's presentation slides and other related resources are available on HPIO's website. You can find those by going to hpio.net and clicking on the Events tab. We're joined today by some fabulous speakers, including two of my colleagues, Becky Carroll and Jude Postolakis. Becky is the Director of Policy Research and Analysis at HPIO, and June is an Assistant Policy Analyst. They're the authors of the brief that we'll be sharing today. Amy Hawthorne from the Ohio Department of Mental Health and Addiction Services will also be joining us to share about trauma-informed care, which is one of the prevention strategies that we're highlighting today. But first, before we get to our fabulous speakers, I'm going to start us off with some brief background on adverse childhood experiences. ACEs are potentially traumatic events that occur during childhood. National data and analysis provide clear evidence that ACEs exposure is linked to poor health and well-being throughout adulthood. Generally, the more ACEs a person is exposed to, the greater the risk of these poor health outcomes. Research literature generally groups ACEs into three categories: abuse, household challenges, and neglect. There's some variation among researchers on what is considered to be an ACE. These that are listed here have been the focus of our analysis at HPIO. Last fall, we released a data snapshot on the prevalence of adverse childhood experiences in Ohio. This data is from 2021, and it's for Ohio adults thinking back and responding to questions about their own childhoods. In 2021, 69% of Ohio adults reported exposure to one or more ACEs during their childhood, and 47% reported two or more ACEs. The takeaway here is that ACEs are very prevalent throughout our state. We also know that some groups of Ohioans are more likely than others to be exposed to multiple ACEs. When disaggregated by race and ethnicity, Black non-Hispanic Ohioans are the most likely to have been exposed to two or more ACEs. And so are Ohioans with the lowest incomes. We also see higher rates of ACEs among children with special healthcare needs, children living in single-parent families, and children living in foster care or with kinship caregivers. When looking at prevalence of specific ACEs, we found that emotional abuse was the most common ACE reported among Ohio adults. The next most common ACEs were substance use by a household member and divorce or separation of parents. We also have analyzed data on the health impacts of ACEs. For example, here we see that Ohioans who have been exposed to two or more ACEs are almost twice as likely to report being a current smoker as Ohioans who have no ACEs. On our next slide, we see that those exposed to two or more ACEs are more than 3 times as likely to report having depression. These examples highlight 2 of the many negative health outcomes that have been linked to ACEs exposure. So on our next slide, today we're focusing on strategies to prevent adverse childhood experiences, including some great work that is already underway in Ohio. So I'm happy to introduce my colleague, Becky Carroll, who's going to begin walking us through the findings of our latest brief on preventing adverse childhood experiences.
Thanks, Haley. Good morning, everyone. Thank you so much for joining us today. HPIO's work related to ACEs started way back in 2020. We released this series of 3 briefs. The first brief explored the health impacts of ACEs in Ohio. Our second publication analyzed the economic impact of ACEs in Ohio. That analysis found that if ACEs exposure were eliminated, Ohio would save about $10 billion annually, and that's just in healthcare and related expenses. And then in our third brief, we wanted to identify things that could be done to prevent ACEs, or at least mitigate the harms caused by ACEs. We chose to elevate 12 evidence-informed strategies. All of these have a positive cost-benefit ratio, meaning that the total societal benefits of the strategy outweigh the total cost. All of these strategies also have evidence of affecting the specific ACEs we identified as having the greatest health impacts in Ohio. More recently, we released a second series of ACEs publications. In these briefs, we took a closer look at each of those 12 evidence-informed strategies, analyzed the extent to which they are being implemented across the state, identified best practices and implementation challenges, and made recommendations of how implementation could be enhanced or expanded around the state. We will also be developing a summary brief that will cover all 12 strategies that will be released in the coming months. But during this webinar, we'll be discussing the brief we just released a few weeks ago, which covers those bottom 4 strategies you see on this slide. They are community-based violence prevention programs, drug courts and family treatment courts, trauma-informed care, and behavioral health treatment. Before we dive into those 4 strategies, we wanted to offer these tips to keep in mind to ensure that any of these ACEs prevention strategies are reaching the most at-risk children. First is to authentically engage communities that are most at risk for ACEs exposure in your planning. Next, it's helpful to understand current and historical community context that may affect your efforts. Then ensure that resources are allocated and strategies are tailored to those children and families most at risk. Reduce participation and engagement barriers. And finally, evaluate your implementation to determine whether your efforts are effective. So now I'm going to hand it over to my colleague, June, who will discuss our first 2 strategies.
Thank you, Becky. Let's see. I don't know if I have control here yet, but okay. Promoting social norms that protect against violence and adversity can reduce exposure to violence and prevent adverse childhood experiences. These norms may include a shared responsibility for the health and well-being of children, reduce stigma related to seeking help, and positive parenting practices. Adoption of these norms increases collective efficacy, which means trust within a community and a willingness to intervene on behalf of the common good. This in turn prevents violence. From 2020 to 2021, 5.1% of Ohio parents reported that their child did not live in a safe neighborhood. However, neighborhood safety is not equally distributed across Ohio. Ohioans earning 0 to 99% at the federal poverty level, and Black Ohioans were more likely to report this, which is driven by structural racism and concentrated disadvantage in these neighborhoods. One way to reduce violence within communities is by promoting norms that are incompatible with violence. And one program that does this is Green Dot, which is a bystander intervention program. Green Dot also educates community members on proactive behaviors that promote positive community norms that prevent violence before it occurs. To inform the section of the brief on Green Dot, we talked to Compass, who implemented Green Dot in Tuscarawas County in 2021. A policy that can prevent violence by promoting norms that are incompatible with violence is alcohol taxes. Alcohol taxes decrease rates of alcohol-related violence, as well as excessive drinking and alcohol-impaired driving. Compared to neighboring states, Ohio has a relatively high tax on liquor, a relatively low tax on beer and wine, and a relatively high excessive drinking rate. Since 2017, liquor taxes have increased by 15%, while beer and wine taxes have not increased. On this slide are a few best practices and challenges for community violence prevention programs. One best practice is to adapt programs to be culturally relevant and connect with communities over shared values. Programs can also collaborate with partners with similar organizational missions on program implementation. Some challenges for Ohio programs include limited funding, which can limit their effectiveness and their ability to obtain buy-in from schools and communities. Other challenges for Ohio programs include grant requirements and difficulty partnering with schools. With this in mind, we recommend that policymakers assist organizations with program implementation through increased funding and technical assistance. Ohio policymakers can also match increases in liquor taxes with increases in beer and wine taxes. There are also strategies that mitigate the negative effects of ACEs into adulthood, as well as prevent ACEs for subsequent generations. One such strategy is drug courts and family treatment courts. Drug courts are an alternative to standard courts that aim to address the root causes of substance use and improve the well-being of participants through treatment and rehabilitation. Family treatment courts are a form of drug court that caters to children and families of individuals charged with drug-related crimes. They were created to reduce instances of child maltreatment that stem from substance use disorder. The image on this slide is of a family treatment program. Oops, I accidentally went forward one step. There we go. The image on this slide is of a family treatment court in Claremont County. Upon completion of the court's program, Ohioans with substance use disorder can reunite with their children who may have been placed in the foster care system. There are currently 31 family treatment courts in Ohio, serving 30 counties across the state. Also, there are over 110 drug courts, with at least one in every county. Most of the state's funding for drug courts comes from the Ohio Department of Mental Health and Addiction Services, or Ohio MOS. Ohio MOS has significantly increased funding for drug courts in recent years. One best practice for drug courts and family treatment courts is the provision of complementary treatment and social services. Providing mental and physical health services in tandem with social services can improve outcomes for participants. Another best practice is the utilization of multidisciplinary teams that specialize in working with parents with substance use disorder. One challenge that drug courts face is that child neglect cases occurring as a result of poverty often come through the family treatment court system. Another challenge to implementation is mistrust towards children's services and similar governmental organizations, which can undermine effectiveness. With this in mind, we recommend that programs develop mechanisms to promote accountability and healthy relationships between participants and staff. Programs can also increase trust among participants through frequent meetings between parents, children, and providers. Now I will pass it back to Becky to discuss the next strategy.
Thanks, June. Our two remaining strategies are trauma-informed care and behavioral health treatment. While both of these interventions can mitigate the negative effects of ACEs, we also view them as prevention strategies. If, for example, a parent is struggling with a substance use disorder, that parent receiving treatment can reduce the trauma and toxic stress that their children are exposed to. But also, those with ACEs exposure are more likely to experience mental health and substance abuse challenges, collectively referred to as behavioral health conditions. There are many types of behavioral health treatment programs and services with varying levels of intensity. It's important for care to be culturally competent, patient and family-centered, and trauma-informed. There are also specific evidence-based treatments for people with histories of trauma. Two examples are eye movement desensitization and reprocessing therapy, or EMDR, and trauma-focused cognitive behavioral therapy. We know that not every Ohioan who needs behavioral health treatment is able to receive it. This is the most recent data we have on the percentage of Ohio children and adults who needed mental health services in the past year, but were unable to receive them. According to this data, this is the case for a quarter of adults and 15% of children. We have many areas of the state without enough mental health professionals. This slide shows the ratio of mental health providers to population by county. Keep in mind that this does not indicate a level of need in each county. It's solely based on population counts. However, we see a lot of our rural counties, for example, without a sufficient number of mental health professionals. Of course, there are lots of reasons behind these shortages. Two examples are provider burnout and the fact that insurance reimbursement rates for behavioral health services are generally low, and that's true in both public and private insurers. Although I will mention that Ohio Medicaid did increase rates in the last state budget. Last October, the Ohio Department of Mental Health and Addiction Services released a plan to alleviate these workforce gaps. It is called the Behavioral Health Workforce Strategic Roadmap. It includes 22 initiatives that will be implemented through 2027. They also have a separate plan to monitor and address behavioral health disparities and ensure cultural and linguistic competency in Ohio's behavioral health system. Particularly relevant to ACEs, the Ohio START program provides wraparound services to parents with substance use disorder to support long-term recovery and prevent their children from entering foster care. The program matches eligible families with a specialized children's services caseworker and peer mentor. This program has been found to be effective in reducing maltreatment, neglect, and out-of-home placements, and increasing sobriety and early recovery. Ohio START is currently in 53 counties. Another evidence-informed strategy we highlight is certified community behavioral health clinics, also called CCBHCs. This is through the Federal Substance Abuse and Mental Health Services Administration, or SAMHSA. This model provides access to comprehensive behavioral health services to anyone regardless of ability to pay, place of residence, or age. The CCBHCs are also required to offer a comprehensive array of services, get people into care quickly, and have crisis services available 24/7. This is a picture of a CCBHC in Lancaster, which is in Fairfield County. It is called New Horizons Mental Health Services. So two of the recommendations we include in the brief are for state policymakers to encourage statewide implementation of CCBHCs and to fund Ohio START in counties that are currently without programs. Our final strategy is trauma-informed care. While not all ACEs are necessarily experienced as traumatic, they definitely have the potential to be. It's also important to note that what can be considered trauma is much broader than what is considered to be an ACE or an adverse childhood experience. We know that ACEs and other trauma can alter child brain development and negatively influence health and well-being into adulthood. Among other effects, trauma exposure can lead to an inability to cope with normal stresses of daily life, form trusting relationships, manage cognitive processes such as attention, and regulate emotions, regulate behavior, or control the expression of emotions. So these types of behaviors we see may not be the result of choices that the child is making or health conditions they've been diagnosed with, but may actually be the result of trauma instead. Trauma-informed care is based on an understanding of and responsiveness to the impacts of trauma. It is integrated into an organization's culture and policies and shapes the way clients and providers interact. About this. I'm really sorry. 1 minute, I'm having some slide difficulties. There we go. Trauma-informed care is integrated into an organization's culture and policies and shapes the way clients and providers interact. A trauma-informed care approach does these 4 things. Trauma-informed care is an integral part of any approach to mitigating the impacts of ACEs and trauma and preventing ACEs for future generations. And while the name trauma-informed care implies this is something that happens in healthcare settings, it's important to note that a trauma-informed approach can be implemented in a wide variety of settings. Some other examples would be schools, children's services, systems and offices, and the justice system. I'll let our guest speaker talk about what's going on in Ohio, but I just wanted to highlight one resource, the Ohio Trauma-Informed Care Certificate. This is a trauma training that is free to Ohio professionals working in the social services, public assistance, and early childhood fields. Participants can achieve 3 levels of certification: trauma aware, trauma informed, and trauma competent. And other than this and several funding streams that Ohio schools can choose to spend on becoming more trauma informed, the state of Ohio really does not have any dedicated funding for trauma informed care. Here are some recommendations related to trauma informed care. First is to have a public awareness campaign on ACEs and trauma. The state of New Jersey has actually done this. They have a statewide campaign called Action for ACEs. Second would be to dedicate funding to encourage schools, healthcare providers, and other entities to become trauma informed. And our final recommendation is for state and local policymakers to require trauma training for all child-serving public employees.
Awesome. Thank you so much, Becky and June. There are maybe 1 or 2 questions in the chat, but I'll let you guys head to the chat to answer those so that we can get to our next speaker. And it is my joy to welcome Amy Hawthorne to the webinar today. Amy is the Trauma-Informed Care Coordinator at the Ohio Department of Mental Health and Addiction Services, where she coordinates statewide efforts on trauma-informed care, connects resources and people providing direct services, and assists with trauma-informed systems change. Prior to this role, Amy worked in prevention and victim services for 10 years as a program manager and comes to us with a wealth of expertise. We're grateful to have you with us today, Amy.
Thank you. Thank you so much, Haley. I am trying, there we go. I'm trying to figure out, okay, I am moving the slides. Success. Thank you all.
Wonderful. Great.
First of all, let me say thank you to HPIO and all of the work that you guys have done. It has been very, very insightful for us, especially because you're showing the impact and you're helping to quantify it and measure it in ways that we can use all of this information to move forward in trauma-informed ways. So this is me. My name is Amy Hawthorne, and below you will see my email address. And please use that. I would like to be considered a resource to you all, a trauma-informed care resource to you all for any questions that you might have now or down the road. So just please take note of my email address if you have anything that might come up. First of all, discussing some of the activities that are going on in Ohio regarding trauma-informed care. I'd like to break it down into our regional collaboratives. So our regional collaboratives serve, you can see the Northeast, lower Northeast, Southeast, Southwest, Northwest, and then we have the Central region. And so how we are looking at the sustainability of these regions and how they're best serving the demographics of those regions. So I wanted to discuss a little bit about the work that is going on within these regions, right? So our Northeast region, they're hosting lunch and learns for professionals that are earning CEUs. They're providing trauma-informed care training free to people who sign up and attend the lunch and learns. And this is on a host of topics, all trauma-informed, and those are happening quarterly. And then our lower Northeast region, they are currently showing a film. The film is called Resilience. And if nobody is aware of the film Resilience, it reveals toxic stress and how toxic stress can trigger hormones that wreak havoc on the brains and bodies of children, putting them at greater risks for diseases, homelessness, prison time, and early death. So what our lower Northeast region is doing is they obtained the rights to resilience. Resilience can be shown to anybody, but it is very behavioral health care clinicians focused. And so what our lower Northeast region is doing is they are giving out streaming for people to stream the film on their own. And they're also hosting larger events where the community can come and view the film, and then they're doing a lot of panel discussions after. So that has been very, very popular. It is not free to view the film, and the film is not on YouTube, and it requires a cost. So our lower Northeast region is providing this film to spread awareness of ACEs and to help people become more aware of resiliency factors of children who have been exposed to adverse childhood experiences, trauma, and also understanding how the PACEs, the positive experiences, can help and inform resilience. Our Southeast region is helping to create a loss team, which is, if people are unaware, I'm sure most of you guys are aware on the call, a loss team is a local outreach to suicide survivors and providing, so they are working with their communities to form these loss teams. And they are also in the process of providing TIC training or trauma-informed care training to law enforcement officials. Our Southwest region is working to bring training and presenters on wellness and secondary trauma, vicarious trauma, to their healthcare staff and anybody that wants to sign up. They're also providing CEUs for their trainings, and they're doing them on a quarterly basis. And if anybody's interested in any of these trainings that I'm referring to, please feel free to reach out to me, and I will be more than willing to give you registration links. Additionally, our Southwest region was very, very active in helping to distribute regulation kits for families. So these regulation kits were created by Tracy Faber, and the regulation kits were created to provide tools for children and families who are on wait lists for services. As I'm sure that people are very well aware, can be a lot of wait lists for families to see providers. And so regulation kits are understandable for all. They do not need a therapist to lead, and they help provide tools that families can tangibly use to think about regulation and co-regulation. So our Southwest region had worked with Tracy to help provide distribution of these tangible kits. We do have access to these kits in a digital form that can be shared. However, they are they're much better used in a sort of tangible way, so that people can open up the envelope and get them out and explore the activity that they're going to do, and so on and so forth. And so these have been very popular, and we are looking at how we can expand distribution sites of these regulation kits across the state. So that's one of the things that our Southwest region is working on. And then moving along, I'm almost done here, is that our Northwest region, they host an annual TIC summit for their region that speaks specifically to the demographics and the needs of the communities in that region that they're serving. They're also, excuse me, they're also looking to bring regulation kits to their region as well. In our central region, we have Becky Haas coming for training, and these trainings are going to be available in person and also virtually. So that's just a quick update on our regions, and our regions provide updates during our monthly trauma-informed care meetings. And if anybody would like to get involved with any of our regions, please feel free to reach out to me. Okay, one other thing that the state is working on, so that you have a little background about myself. I started in this position April of 2023. And so the strategic plans that had been set into place, they were ready for an update. However, me, new in my position, I was still doing a lot of learning and a lot of observing, and I wasn't quite ready for a formal strategic planning process. And so what we did instead is we created a charter draft to work through to help guide our work. And this charter draft serves as a purpose to help, kind of keep us in the realm of what we would like to accomplish until we do a more formal strategic planning process in the fall of 2024. So we do have a planning process on the books, and I do welcome ideas and thoughts around that. We will definitely be using a lot of the work that HPIO has provided. So thank you for that. But basically, to give you a very brief scope of the charter, we aim to operate with a DEI and trauma-informed care lens, and we will continue to think about trauma-informed care within the 3 domains, which are clinical, cultural, and organizational. Those are very important domains, and that we would like to see thread throughout our trauma-informed care work and initiatives, and so that we are reaching all of these different populations and people. We're thinking about them, as service providers. We're thinking about it from a cultural lens, and that we are providing trauma-informed care to our organizations, both internally and in the people that we're serving. So another big project for us is to support and sustain our regional groups. We would be nowhere without our regional groups that I just spoke about previously. They are our boots on the ground. They help provide a lot of feedback about what they're seeing and what the needs are for those specific regions. Because one important thing, while we do know trauma-informed care is, necessary and needed, it cannot always be a one-size-fits-all approach. So we want to look at tailoring work to community and regionally based needs, and definitely hearing what the people are needing. And lastly, to speak on the charter briefly, we want to promote shared language across disciplines and across regions as well. And so, we might have a lot of buzzwords, or we might have a lot of acronyms that float throughout different disciplines, different educational spaces or mental health spaces. And so we're trying to really focus and hone in on a language that is digestible by everybody. And so we don't get caught within a jargon space. Oh, I need to go backwards. Oops. I keep going forward and I'm trying to go backward.
The arrows on your keyboard should work.
Thank you, Haley.
Of course.
Okay, they're not working.
All right, Jasmine can step in and manage this.
I apologize for the... Okay, if we could continue to go back.
Try doing it now, Amy. See if you have control. And try clicking your screen first and then using your arrow.
Oh my gosh, thank you, Jasmine. Thank you, everybody, for your patience. Okay. Next, I would like to promote for everybody, please, if you are interested, I encourage everybody to come to our annual Trauma-Informed Care Summit. This year, we're hosting our summit at the Hilton Columbus Polaris at 8700 Lyra Drive. We're hosting the event on May 8th and 9th, so it's a 2-day summit. It's our 11th annual Trauma-Informed Care Summit, and we're really, the theme is a time to reflect, adapt, and innovate. And so we're really thinking that, we've got a lot of great research coming out post-COVID. And we didn't necessarily want to focus on that, but we definitely wanted to include that and thinking about how, the reflection of the last couple of years, how our resiliency skills have adapted and how we can move forward in innovative ways. And so that's why the planning committee decided on this theme. And we're very, very fortunate this year to have 3 financial partners. So we have the Department of Developmental Disability supporting us, the Department of Youth Services, and the Ohio Department of Health, all partnering with us at Ohio MAS to bring this summit and these very important presentations to Ohio. Our keynote is Cherie Ting, and she is going to be speaking on organizational trauma-informed approaches. And so we had a couple of struggles with the registration link, and so it was opened and now is closed. However, I do have word that it is going to be reopening again today, this afternoon. So please, if you saw an error in registering, please try again. The link should be up and operating by this afternoon. And then just to speak briefly on how a lot of our work aligns with HPIO and their best practices, and what are some of our approaches in alignment are the cross-sector, cross-systems approach, involving people with histories of trauma and planning. We like to bring lots of voices to the table, and if you attend our summit, you'll get to see and hear a lot of lived experience, people presenting and sharing their experiences with resiliency and with trauma. The goal is to maintain strong leadership and to begin trauma training early in post-secondary education for healthcare, and educational professions. So that's not to say there aren't other areas with alignment. These are just recognizing a few of those. And then one other thing that I briefly wanted to mention was the new source study that was excuse me, the new source study that was released a couple of weeks ago. If people were unable to see it, there's a link in the slide that will take you to more detailed information, but it is a big research initiative funded by OhioMOS to identify the root causes of ongoing epidemic of persistent emotional distress, suicide, and drug overdoses in the state. And so this will investigate the role of biological, physiological, and social factors that underlie this, the epidemic, the toxic stress, and understanding how ACEs play a role in that is something that will be very prevalent in this work as well. And then the last thing that I wanted to mention is that we have free trauma-informed care courses on eBased Academy. So eBased Academy is something that if you are unaware, you can sign up for it for free, and you just make your own account. But there's lots of different trainings on there, and we have our trauma-informed care courses up there free for anybody that wants to take them. And we have them organized in the way that they're clinical, organizational, and cultural. So you'll be able to see the different learning catalogs. And also one thing that I wanted to mention is that you can take those trainings that on your own time, and you can sit down for say it's a 4-hour training, you can sit down for an hour, do an hour, take a little break, you know, because the material is quite heavy. So maybe you need to take a little break and come back to the work. That is always an option. So it's very user friendly. And the certificate program that was mentioned earlier will use a lot of the trainings, the trauma-informed care trainings that are on eBased Academy. So that concludes my presentation. And if anybody has any questions, please feel free to ask them or to email me.
Thank you so much, Amy. We are getting a lot of interest in the chat for the resources you've talked about. And I did share the link for the Trauma Informed Care Summit. So as Amy said, if it's not working for you, keep trying. Amy, I do have one question before we wrap up. Can you give us an example of an example that really sticks out in your mind of when an organization adopted a trauma-informed care approach and it ended up being very impactful? Like, what did that look like? What did their journey look like?
That is an excellent question. Something that raises to my mind initially, there are, you know, lots of success stories, and there's also a lot of organizations, agencies, schools that are going along that path where there are a lot of, you know, bumps and hurdles. But one key area that is coming to my mind is Warren City Schools. And so Warren City Schools, they are fortunate enough to have a trauma-informed care coordinator within their school at their district. So that's already, you know, a leg up on a lot of our districts. But they incentivized all of their school staff. So this is all of the teachers, all of the administrators, people who are bus drivers, people who might be in the janitorial parts of the school. So they incentivized people to go to the Mayerson Center's trainings, virtual trainings. So if people are unaware, the Mayerson Center is out of Cincinnati Children's Hospital, and they give free virtual trainings specifically on trauma-informed care, specifically for educators. And so it was very successful for them to be able to get all of their staff trained and ready to go. So this was a big feat for them to be able to incentivize their staff. And then they created small circles, small like think tanks, conversational circles, where the people who went through the training could then have conversations about how they could incorporate more trauma-informed care into their classrooms and into their schools.
Great.
And so
Wonderful.
sorry, I was just saying that was so brief and they did so much more detailed work, but in the interest of time, I want to be brief.
We appreciate it. We appreciate all of you for attending today, and Becky, Jude, Amy for sharing your expertise with us. As we wrap up today, we're going to invite you to take some poll questions for us. Our hope is that this work is helpful to you in your effort to influence policy and improve health and well-being in our state. There are so many ways to do that. We have a quick slide that shows some of those ways. We would love if you would respond to these poll questions, give us a sense of how you enjoyed today's webinar and how you plan to use this material going forward. There are a few questions here, if you wouldn't mind scrolling through and answering those. I mentioned this in the chat, but a lot of links were thrown today and a lot of great resources, and we will make sure that those are rounded up and placed on the event page for this webinar so that you all have access to those after today. There will also be, as soon as you exit today's webinar, you'll see a window pop up in your browser, which will give you an opportunity to provide us any written feedback you have about today. So be on the lookout for that as well. Thank you all so much for being a part of today's event. We appreciate your engagement with our work, and we hope you have a great rest of your day. Thanks, everyone. Thank you, thank you.
Thanks, Haley. Everybody have a good day.
Thank you.
Thanks so much, Amy.
Thank you, guys. Thank you. Let me know if I can do anything to help.
Great. We might send you a couple follow-up questions.
Perfect.
Thanks again. You did a great job.